Eating disorders are not about vanity. Ooh, can I change that misconception? They are about survival.
But they do often, I'm not going to challenge you on that.
You can challenge me.
I agree with you that ultimately it is, but like, they do, you know, I would argue that mine began as a motivation to be thinner and look better.
Okay.
I don't know if that's even vanity. I think it's okay to want to look better. I don't think you have to be vain to want to look better, by the way.
What's under wanting to look better? Acceptance.
Well, aren't you allowed to want to look better and still accept who you are in the moment?
Depends on how far it goes, in my opinion, right? If it goes as far as changing what I eat or adopting unhealthy compensatory behaviors, then I think it's more about acceptance or the risk of feeling excluded. And let's go back to borderline pathology. The first diagnostic criteria is behaviors aimed at thwarting real or imagined abandonment. You know, go back to billions of years ago, living in groups was protective. If I did something that made the chieftain angry and I got put out of the fort or wherever we lived, when the tiger comes, I'm not going to have too many people to help me survive. I think that's really important.
Right. So, but now let me add, when I would argue recovered from the eating disorder, right? It was just no longer a thing, and I thought everything would be fine. That was when the borderline stuff really surfaced for me. And it was like, because I never understood why I had the eating disorder. Like, I never understood what it did. I understood its function in the context of the work I had done in the program, how it allowed me to step away from life instead of put myself out there and face the discomfort of challenges and the uncertainty that they presented and that I might fail and all those things. So it kind of removed me from that opportunity.
Safety.
Yeah. Yes, yes. So it took me away from that. So I knew that. But when you really no longer have the behavior for a long stretch of time, you're being given a tremendous amount of space, or a tremendous amount of space opens up that had heretofore, you know, just not existed because it had been co-opted by the eating disorder and all of the craziness, quote unquote, that you have to engage to maintain it. That was when the borderline stuff surfaced. And so, and there was no skill that I could use to fix that problem because the eating was no longer a problem. So I was like, but the eating is, everything else is a problem, but the eating isn't a problem. But yeah, what happens, like, how many people do you think have a crossover with something that once the eating disorder does truly resolve and they are recovered, there is another personality disorder, psychopathology beneath that needs addressing?
Most.
Most.
Whether it's depression or anxiety.
Interesting.
I think meds need to be managed during the early stages of recovery, because if you have a restricting eating disorder and you're malnourished, your body's compensating in all sorts of ways and you're probably not metabolizing medication as effectively as possible. So medications, they don't have an anorexia or a bulimia pill. You might medicate symptoms around it. The early stages of recovery are the most susceptible to a low, a lapse, a relapse, because people ask themselves, remind me again why I did this? Because it seemed a whole lot easier to just purge and get rid of it, get the endorphin rush, then feel kind of calm, than this, being anxious all day, or, you know, I thought my life was going to be perfect. No. So early stage of recovery is a lot of work protecting the fragile. Your recovery at that point, I'd like to give it a metaphor of sort of a fine piece of crystal. It's fragile.
Let's say, so, or rather, are you saying that the co-occurring diagnoses that probably exist with most people who have an eating disorder don't bubble up until the symptoms remit because the symptoms have been essentially protecting you from having to manage this other deeper,
right,
thing.
I think
or not.
That psychiatrists will be able to observe it more. I think the symptoms become more prominent to the person based on discomfort and family, people surround in your orbit. It's not really that they weren't there before. I think they were there, but the eating disorder was kind of like sitting on them.
Absolutely.
If that makes sense.
Yeah.
Yeah. So they become more prominent to be observed and addressed.
Right. So do you think, is someone who is an eating disorder therapist the best equipped at that point to do it? Or do you think, would they be better served working with someone who specializes in that area?
It's so interesting because I believe that eating disorder therapists are schooled in depression and anxiety, and those are going to be some of the biggest ones you'll see. You will also see some obsessive compulsive traits.
Yep.
So it's important that the clinician understands screening methods for different underlying ones, and that the person is aligned with a psychiatrist, maybe even some testing that's done if it's helpful. But I do believe that eating disorder therapists understand enough about the mood disorders because they are prevalent in the eating disorders. Because if you look at what was going on right before the behavior, I don't know, depression, anxiety, feelings of being overwhelmed. Oh, I would call that anxiety. What are your skills for anxiety? It's so interesting. I think in answer to your question, I would retain, and of course I'm biased here because I'm an eating disorder therapist, but I would retain the eating disorder therapist for a while because there's so much symptom substitution. So consider the person who is a restrictor initially. Let's say we have an adolescent who's a restrictor. The eating disorder's been identified, they are in treatment, and let's say family-based treatment, and the parents are in charge of the food, and there's all sorts of conflict around meals, and the patient or the client is encouraged to eat larger amounts. That's the treatment. When he or she starts eating a higher volume, there is at least a 50% chance that he or she will engage in some compensatory measure, because not only do I have to eat more, all of a sudden my family is on me like hawks, and they're watching me. So I have to eat more, and I'm being watched 24/7, and now I'm really uncomfortable. So I want to validate again my understanding. It makes sense to me that people would want to shift to a compensatory behavior. Orthorexia is very common. It was labeled, I think, in the mid-90s by Steve Bratman. I think it falls under the ARFID diagnosis, avoidant restrictive feeding intake disorder, which is kind of a new one too. We're trying to figure out where to put all of these behaviors. I know if you read pop psych or social media, there are things such as brideorexia. That's somebody who wants to lose a large amount of weight for their wedding, right? And they actually have some tube systems that, it's that scary. Where food is extracted from their body so they can fit in the wedding dress that they chose. That was several sizes too small.